Good morning, colleagues at the conference. I am Sibisi and I would like to welcome you this morning to day 2 of our conference, and I'm bringing you a very interesting speech on rural health equity. So first of all, I would like to thank the organizing committee and the delegates and the Limpopo province, Bila in particular, for hosting us. A beautiful setup indeed. So this morning, I'm just going to talk to you about working with traditional healers and leaders for equity in healthcare in rural areas. And please take note of that title slide. It tells you it's rural. I would like to ask you a question, just by show of hands. Which services do you use? Biomedical, African, yeah? African traditional? Oh, no African traditional. Oh, okay. So how many European traditional? And who use both traditional and okay. Seems like a lot of us are rather using biomedical services only. Interesting. So I grew up here. You see that place? This is a place that is forever green in the summer, beautiful. That river runs right behind our yard at home. And that's where I used to swim as a child, and that's where my children swim at when they are at home. The women you see there, they raise me. And for them, ensuring my health and well-being meant taking charge using their own methods. I don't know if some of you would remember this. Anyone else? European traditional, familiar with this? Not, okay. So you see, when you are a child growing up in rural areas, ukuthatha, as they say, ne, is a primary healing method in children for fever, cleaning the stomach, or taking out what bad spirits that might be, bothering the child, etc. So we know this all too well, and it wasn't pleasant going through it. So it is very traditional, and rural health folks are very rooted in their traditional methods. So ukuthatha or enema, ukuhlanza or purging, all of these are strongly linked to African spirituality. So it's not just cleaning the gut, for an example, it's more linked to the well-being spiritually. So this is a common occurrence among rural populations. And just to paint a more serious picture about rural as well, being, from a rural background, there are certain customs and traditions that are kept when children are born. There are certain rituals that are done by women, for the women and the children that are born to preserve their health and well-being. And all of that is very strongly linked to the ancestors. And usually at childbirth, men are not allowed to be part of the childbirth, or even for a couple of days or even a few weeks thereafter. All the way to death. So you see, for an African child, from birth till death, their life is guided by ancestors and rituals and traditions that are kept. And that comprise of using umuti a lot of times, doing certain things to ensure that you are constantly aligned. And that is then when a person is well and healthy. So even in death, we still slaughter. There's a great significance in slaughtering. there's certain burial rights that are kept. If not, you can be sure that the person that has passed is going to come back to ukusihlupha, ne? And then cleansing is very important. You cannot be uncleansed after a death of a loved one because their spirit is going to cause disease. So why am I telling you all of this in the background? I'm just trying to paint to you, just to give you a bit of a snapshot around traditional medicine used by rural people. But we do know that here in South Africa, we have parallel healthcare systems. A lot of people are using both biomedical services as well as the traditional services, as you can see. I would like to point to that picture on the left. These are the rural health students, the rural health class of 2016 in Bushbuck Ridge. So that's where we were inspired, seeing that indeed collaboration can exist between biomedical and traditional services. Research has also shown that although consultations with traditional healers is costly, ne? People still do go there. And actually, the poorest of the rural populations consult traditional healers, and that's their primary service that they use, regardless of the cost. But why is that? So Prof. Musa and his colleagues found that clients are happy to consult because there is continuity of care. They feel connected. They are understood by the traditional healers. And even these days, these are the traditional healers of today. Look at them. They slay. They are on, they use social media. They are very much easily accessible because they are here. So a lot of times, some consultations are even done on WhatsApp or video call. So things have actually gotten better regardless of the cost. So clients are generally happy with traditional healers. However, research has also proven that there are things that we don't want to see happening, like delays in treatment start, especially in the cases of antiretrovirals, people getting sick, people even ending up dying because they are still trying out these traditional methods that haven't been proven to work. There's also worries about possible drug interaction with these herbs. As I said, they haven't been proven in the labs if they actually, you know, do work, or even if they do work, the dose and the route of administration. So South Africa does have the Traditional Health Practitioners Act 22 of 2007 in trying to align and legitimize traditional health practitioners. They aim to establish the Traditional Health Practitioners Council of South Africa. But let me tell you something about this council. It's not up and running, it's not operational, and I'm sure all of you know why. There is a lot of bickering among the biomedical and the traditional health practitioners, lack of respect for especially the traditional healers, and the difference in, you see, for medicine, you have to go for training in school and read books. But for traditional healers, training is spiritual. You cannot put it in the book. You cannot touch it. It's an experience that the person goes through. So some have asked me, how do you think we are going to get this done? Because they undermine us. They see us as nobodies, yet we are doing so much. So nevertheless, it is a good start where we are. to say, let's have this Traditional Practitioners Council of South Africa. However, leadership thereon seems to be an issue because no one wants to get their hands dirty. No one knows where to start. I want to show you what some of the traditional healers have said. These are the healers that I work with from Mkizwaneni, and I threw this question at them. What do you think about collaboration with the Department of Health, in South Africa? And they were very strong on this to say that one said, I don't think it would work. Somehow they'll exploit the knowledge shared by our healers as they always do. And by they, I mean the big pharmaceutical companies who have a grip on our government and the operations. Another said it's great on paper, but not in reality. Well, that's my opinion. I know for a fact, if me or anyone in our team would work with them, they would want to kill us by the end of the working day. Because everyone wants to bring in their point, and where there is no mutual respect, there's nothing you can do about it. And some interesting points are healers are versatile and they work differently. They are trained differently, and most training is done by ethos. Things can't be filed, recorded. It's a secret. You can't just share because now we are regulated, therefore let's give every part of it. The same way they can prove astral projection on science level is the same way we can prove our spiritual sciences. So some had a take on, but we can prove that this works if only we were funded. So this is their voice, this is what they are saying. But mainly what stood out, traditional health practitioners do not want to work with the Department of Health. They do not want collaboration unless there is respect, unless there is an understanding. Some go as far as saying, perhaps the medical people need to just get the introduction into African traditional, healing and understand what it comprises, as opposed to them sitting there driving policy that say, let's collaborate and take us to training for. So we all know that a lot of traditional healers have been trained. I mean, in our sub-district trainings, etc., they've been introduced to the basics of HIV, how to go about, but is that enough? Is that really all that we need them for? Is that the collaboration that we want? I wonder. It brings us to bi-directional referral ways. Are they bi-directional or one way only? Is it only, let's train you so that when you identify opportunistic infections for HIV, then you refer to us? What happens once these patients are referred to the biomedical services? Is there a back referral to them? And this is what causes patient disclosure about traditional health practitioners' consultation. They will never tell you because they know that we are going to start talking about drug-drug interaction. Why are you doing this? Make them feel bad for doing something that they believe in. You see, with belief, you can't take it away from a person, but you can only work around that. So we need to think as healthcare workers. Are we doing justice to the people? Or we just want them to do what suits us while we are at the hospitals and the clinics? So while all of that, regulations and things going on, life goes on, it doesn't stop. People continue to boil their gum tree leaves for COVID to steam. They still purge, they still kata with all sorts of herbs, different dosages, different strengths of the treatment, which even I can't tell you what the effects are. They will do it. Whether there is a traditional practitioners council in place or not, they continue, life goes on. So what can we do while we wait? I took this from this guy because it's very inspirational for me to say, what can you do where you are when you want to work with people? And if we go to the people, live with them, learn from them, love them, and start with what they know, we can build with what they have. When the work is done, then the people will actually say, we have done this ourselves, you know. But if you are going to come from outside and want to impose on what people already believe in, you know, they already have these systems in place, they are not going to listen to you. We know that people continue to use traditional medicine. We don't know, they know how beneficial it is for them. We are concerned about drug interactions, late start of treatment, etc. But do we really want to listen and understand why they are doing what they are doing, and how then we can balance the two, biomedical and traditional? Instead of telling them, no, stop using that, now you are going to take this from now on, and you send them back to the same context. So we need to think a bit deeper. So one of the ways we can actually start is engagement with stakeholders on the ground. We all know stakeholder engagement. I can't emphasize that any further, but in this case, engaging the traditional authority, trying to understand a particular community, their customs, norms, how they do things. A Tswana community somewhere in the Northwest is definitely not like some community in the Eastern Cape or in rural KwaZulu. They have different cultural norms, and so you need to understand who they are, where they come from, what they are about, what are their values. And then engage the traditional health practitioners, because that's their primary healthcare providers. Engage, because all of that is based on their values. Engage other community gatekeepers and the community itself. We know that we have influential people in the communities, and we do have the political, space around that. And other government departments, how they can come, on board in trying to get things off the ground with us, as opposed to working alone, because everything else is really integrated. So these are the type of people that we need to be familiar with and know how to engage with them. As I've earlier said, that there are certain values that they uphold, and there's a certain manner in which they are addressed, and a certain way that you conduct yourself when in their midst. I'm sure most of you know about this. We can't do anything if we do not reach out and advocate, get into the communities, get your hands dirty, understand the people, learn why they do things the way they do before you even come in with what can work for their benefit. Rural nurses have a lot to do when it comes to this dilemma that we are having, that there is poor collaboration between biomedical and traditional health practitioners. You see, a rural nurse is on the ground. They live in these communities. They live with the people. They understand the cultures. So they should actually be in the forefront of influencing change in the rural communities and make people be more accepting of biomedical services without leaving their beliefs, né? And probably see how they can balance the two. I would tell you this is because I have done it personally, to say I'm engaging with the patient, right? And I find out, so what are you taking? They could be going through a cleansing, maybe a loved one had died. And we know that some routes of medicine administration is ukukhatha or purging, ukugeza, that is spiritual bathing. What else is there? Ukuguma, ne, ukufuta, or even just putting something on the top. So you work with a patient to say, okay, right now I'm not so sure around this, but yes, we are concerned about drug interactions. How best can we do this? What route of administration is there that you can use for this particular treatment that you are taking? Could it be perhaps steaming? Could you steam instead of ingesting it? You know, ukuthatha, you check. But ukuthatha is quite hectic because the medicine goes right into the bloodstream. So you negotiate based on what is it that they are taking, what is it for, and are there other options instead of saying, look, wait, you're now going to take this, leave that. They are not going to do that. And that's why you find them going back home, put aside your pills and continue with their treatment. So we need to be more compassionate when we are consulting these clients and understand their concerns and make them be able to open up and say, yes, I was consulting Inyanga and they gave me this and this and that, and plan your treatment accordingly. So in conclusion, I don't want to step on toes here, but I'm going to say it. It's good that there's been attempts at recognizing traditional health practitioners, although some say, we don't care about being recognized by them. For what? Are we doing what we are doing? We are helping the people that need our help. We all know that the principles informing biomedical services are mainly Eurocentric. That's an honest truth. And here we are trying to, within that space, to say, okay, let us understand, let us integrate, but how are we doing that integration? It's difficult for African traditional healing to resonate with medicine because it's completely different, you know? Here it's beliefs, here it's based on science. And there is no helpful solutions without harming the traditional health practitioners and the users. I think what I've just demonstrated here makes sense to that. So we need to rethink literature informing medicine for users of both systems. It can't just be one way, while we know that people use both. Understand always that the patient is at the center. And lastly, the frontline rural nurse can make a positive influence, can make a positive influence to adapt to both systems so that the patients are not lost through the cracks. So with all that said, colleagues, there is a rural nurse there. When she's home, taking off her shoes and everything, she just goes and sits under the tree and breathe. We all need to breathe and understand people. So I would like to thank you. Oh, thank you. Do we go here? All right. Okay.
So what I'll do is, again, yesterday, my best friend would like to comment on chat. If you'd like to contribute, please just put up your hands or put something in the chat, and I'll keep an eye on it. I can wait for the form. If you'd like to comment.
Either you can check. And then? Maybe I'll stop sharing. Okay.
Well, I'll start.
Okay.
Oh, there's somebody. Great. It's coming.
Yes, good morning, colleagues. Thank you, Tansen, for such insightful classes. It actually reminds me of a patient I once encountered some time back when I was still a dermatologist doctor. This guy had a diabetic foot, which with wet gangrene was foul smelling. The ulcer was starting to encroach onto the veins. So he was kept in the hospital because every time they wanted to refer him to a higher center for intervention, we'd always talk about his traditional healers that he was only brought here for IV fluids and all of that. Up until I went to him and I sat with him and I asked him what is stopping him from being transferred for operation further management. That was after 2 weeks in the ward. Then he said to me, he can only go once he gets a blessing from the ancestors through his traditional healer. So what I did was I asked for the traditional healer's numbers, called the traditional healer into the hospital for the traditional healer to come and talk to his client. I also explained to the traditional healer what is going on. After about 30 minutes of interaction between him and the traditional healer, he agreed to be transferred. Because the traditional healer acknowledged that that was beyond his capabilities. That was something that had to be managed in a biomedical kind of approach. But unfortunately, it was already too late. By the time he got to the referral center, he died from sepsis. Because we, as the doctors, did not want to acknowledge his belief. We wanted to impose ourselves onto them. And so the outcome was a dead patient. I remember Steve Reed used to run this project in case around the Valley of 1,000 years, around that particular area in KZN. And when I went there, I was quite fascinated to find that the traditional healers can actually bring a patient into the clinic facility and say to the nurses that, you know what, from here going there, we can't do anything, can you please assist? And the traditional healers themselves also still had responsibility of their patients, in that after the nurses had finished whatever they were doing, so when TB was still right, the traditional healers even became the dot supporters for their patients who wanted to be medication. Why? Because there was mutual respect between the clinicians and the traditional healers. So by this, I'm saying thank you. It was a great presentation.
Thank you very much. We have another person coming up from the Victor's coming up. Always just introduce yourself before you start speaking.
Hello, I'm Victor. I worked obviously in a very traditional community for a long time. And I think the point that was made by our speaker is very fundamental, that we interpret other people's practice in the light of our own beliefs and understandings. And there's no way that we as medical people can attempt to regulate traditional medicine because it's based on a totally different premise. So very often when we talk about interacting with health practitioners of another type, we're actually talking about persuading them to follow our models. We're not talking about using their model. We're not talking about their belief system. Now, we know that everybody in the world believes different things about different things, and we have to respect people's beliefs. It does not mean that everybody's belief is correct. There is such a thing as error in the world. And that's very arrogant of me to say that, I know. But that's not Western European or Eastern Orthodox or Chinese or African. That's just reality. There are things error and there are things that are true. The problem is trying to sort out the difference and understanding where the truth lies. So it's very arrogant of Western medicine, or we call it Western medicine, scientific-based medicine, to say it has all the answers, because we know it doesn't have all the answers. But there are many practices that we know are harmful, and we'd like people to stop doing them because we can show evidence-based that they are harmful. And that's generally what happens when we doctors of a biomedical type get involved with traditional healers. We try to turn them into healthcare workers on our model, and they can do the other thing to attract their clients. It isn't really a synergy of traditional medicine and biomedical approach. And I think you're right that it's something that the traditional healers have to regulate themselves. It's not something that we as doctors can regulate because we don't live in that space.
Thank you. I would also like to add, and then I'll ask you to come. Great, yeah. So I'm Madeleine. I'm from the Eastern Cape. I'm very passionate about this topic. The WHO has something called a section on traditional and complementary medicine, where they are trying to look at more the safety, looking a little bit at effectiveness, but they also understand the challenges of trying to use an evidence-based model, trying to define traditional practices. So they look at TCM, your traditional Chinese medicine, Ayurvedic medicine, homeopaths, chiropractors, osteopaths, so all of these big European movements. I mean, there are more traditional Chinese medicine doctors in China than there are medical doctors. They do a 7 years training, and they do not work in the same evidence-based practices. The theories are very different in how they look at medicine. So that's quite interesting that in the world, there's more and more of a conversation about how do we not sideline practices because it doesn't meet our definitions of evidence-based. So I've got a couple of words around evidence-based and traditional medicine. So we are nowhere near getting to the point, although all doctors would love, can we get an evidence-based for traditional medicine? But we have to understand how little evidence-based we have for a lot of the stuff we do in medicine. So although we have a bulk of things we can say is evidence-based for hypertension or diabetes or whatever, a vast amount of stuff that our patients come to us with and the methodologies and techniques and ideas that we use are not evidence-based and will never be evidence-based. And I think part of a consultation, and this is very family medicine, is the process that you follow with the patient. And then there's your tablets that you prescribe that's either going to be good or bad for your patient. And I think what's very powerful in traditional medicine, we might not have much information in terms of the evidence base of the actual remedies that they use. But certainly they are experts on process with their patients, and we don't give recognition for that. For us, it's all about, does the tablets actually work? And not enough recognition of the art of the consultation and the art of the process, and being in those communities, standing in those communities, and using that same health beliefs is extraordinarily powerful as a health intervention for our patients. And just about the harm thing, so I agree, we're always worried about harm. Our medicines are much more harmful than what most of the traditional medicines used. We do see drug-induced liver injuries with traditional medicines. I've seen a lot more drug-induced liver injuries with TB medicine than I've seen from traditional medicine. So we are slightly arrogant in our bias about how terribly harmful and how useless traditional medicines are. And actually we need to look at what we can learn about process from the traditional healers instead of keep on trying to teach them about evidence-based medicine. My 2 cents. And yes, lovely to have the nurses at the conference. It's really.
Morning, everyone. Thank you, Ntabi, for a powerful presentation. Indeed, we did not deviate from the nurses' pledge, which says we will not let the belief or religious consideration stand between me and patients. So as a take-home message, we need to encourage those clients of ours that believe in traditional medicine of how to use it to their benefit.
and not to wait too long before it is too late. If we thought traditional medicine isn't good, we wouldn't have been having that solution that we prescribe as doctors or as nurses when someone is having a homemade one, to say you can do a sorrel at home before you can take your child here. So our take-home message is we need to strengthen our partnership with these cadres moving forward so that we benefit our patients. Thank you.
Thank you very much. Yes, Lindy, do come forward.
Everyone, thank you for such a presentation. This is Lungile from Seleni. I think for me, mainly earlier in my years, I was just reflecting about it. In practice, so earlier in the years in practice, so like internship, conserve, I struggled a lot with patients that will come in after a traditional enema and they would die, to an extent that at some point there was a movement to try and criminalize it because we labeled it as enema poisoning or intoxication. And I think that we probably ended up taking up a stance that we shouldn't have. And as a result, that has actually added to barriers between us as practitioners of Western medicine or scientific-based medicine. And thank you, Madeleine, for what you've said about how many drugs do we use that are actually toxic. And some of our patients have actually died because of some medicines that we've given. How many practices do we practice and they are not actually evidence-based? Up until a point where I actually realized that the intent to give an enema to a sick child is not to kill them. So how can you criminalize an innocent and noble act of saying my child is not feeling well? I am trying to do something to get them better. Thank you.
Thank you very much. Oh, is there a hand up there? Excellent, well done. So yeah, Maputi, will you please unmute yourself? There we go, thank you.
Okay, thank you so much. Just to add on to what the last speaker just raised, the question I've always had, or the problem I've always had with traditional medicine is, when do they stop and when does Western medicine start? Like, at what point is a patient supposed to see or know that, no, this one, I have to take it to the doctors at the hospital for Western medicine, and this issue or this illness that I'm having now, I'm supposed to take it for traditional medicine? Because I was on call in Jubilee just the other day, and this mother comes with a baby, just like the the last speaker was speaking about enemas, and the child has a lot of traditional things on the stomach everywhere, and it becomes the child looked very sick. It was like a really sick child. So now I asked myself, why did the mother not start with Western medicine? And then maybe if she sees that, no, the child is not getting better, it's failing, and then take it to the traditional. Because now when you bring a child that's complicated and whatever, it makes us wonder about your reasoning capacity as well. Because what I'm thinking is, the last speaker was saying, why would you not prosecute somebody or a traditional healer that was giving a child an enema? But then if we do not put laws to regulate the behavior or the activity of the traditional healers, we're actually we're going nowhere. Mama, I would say that in working with our traditional healers, the idea should be try Western medicine first. And if it's not working, then go to the traditional healers. Rather than go to the traditional healers, do a lot of things which, you know, the traditionals don't come with the with the patients to hospital. You don't know what medication has been given to the child. You don't know what toxin you're supposed to be looking for an antidote for. Oh, yes, a lot of the drugs that we're using have a lot of side effects, and they're complicated, and all our practices are not evidence-based. But the majority of what we're doing, we can back up with science, and we can say, you know, we gave this for this and this, and somebody can follow our process. So try us. I would say try the Western medicine first, and if it's not working, I'm not against killing a cow or whatever to the ancestors before before you bring the child to hospital. That I think is okay. It's your spirituality. But I'm against injecting the child, giving enema and giving other things, and then bringing a very, very sickly, and where we lose the fight before we even start. Thank you so much.
Thank you very much. Would you like to reply to that at this point? Yes.
Thank you very much, Dr. Maputi. You know, I'm looking forward to a time when one day we can have traditional healers that are based in our clinics, right? Just like doctors who are visiting. So can we have traditional healers in our clinics where consultation can be both Western and traditional for those who want, and thereafter there is a discussion between the primary healthcare worker and the traditional healer in terms of the findings and what the best course of, you know, action for treatment is. For me, that is collaboration. But to sit on the one corner and make assumptions about the other, I don't see where that's taking us. So we need to be more sensitive, and really, much as they say the council should be in place, it shouldn't just be on paper. That's exactly what should happen. If the healers come on board, this is what they should say, to say, okay, then put us in your clinics, put us in your hospitals. How is that?
One speaker here, and then I think, Herman, we can finish with you.
Thanks, Ntaba Singh. That was a lovely talk. Kate from currently President. I just wanted to comment on, if we're looking at universal health coverage. Marek presented yesterday on catastrophic health expenditure for people attending rehab. It's something that concerns me a lot when I see families spending what they don't have on traditional healers. And I mean, if we're looking at the whole thing of regulating a bit better, organizing a bit better, I really hope that some form of looking at costing would also help. It's another area that I don't understand anything about, but one does sometimes get the sense that families are taken advantage of by traditional healers who charge undetermined amounts of money.
Hello, it's Herman from the Garden Route at the moment. I've worked extensively in rural areas in Eastern Cape, KZN, and Eswatini. And I think that if one works at a hospital and see people that come towards the hospital, one has got a very biased impression of what happens in the community. I work mainly at clinics, and 90% of the people that I put on ARVs are doing very well. But every now and then there's a patient that is not doing well, and I send them to the hospital. And the hospital doctors say, yeah, you're messing up these ARVs completely. Because every patient that I send to them is messed up. And we went, when I worked in a show in KZN, whenever there was a mother that came in with a baby with fetal distress, Yes, did you use this basal? Yes. That is causing the fetal distress. Yet our textbooks give us 20 reasons that cause fetal distress. It doesn't mention the basal. And if you ask every woman about it, every woman has used it, but only 10% get fetal distress. Sorry.
Discussion's getting more and more fun. Okay, we actually do have, so we actually, it's great. There's been, it is enough of discussion. Is there anybody else who would like to, now we've got, oh, look, we've got a hand up there. Adam Diaz, would you like to unmute yourself?
Sure. Actually, I was just applauding what Herman was saying, but now that you've given me the mic, I'll say something. Adam Askar, I'm from eThekwini and Ilembe. Just in reference to the collaboration, I think, sure, we can look to a formal collaboration in the future where there are traditional health practitioners in biomedical facilities, but I think we can also work towards a less formal collaboration. Like WhatsApp breaks down a lot of barriers, and I think if the traditional health practitioners in my area, perhaps if I took the time to distribute my number to them, then and say, let's talk. If you have a tricky patient or whatever, I think that would be a good step towards informal collaboration where, you know, maybe they're not sure about something and they just want to run it past a biomedical person, and it can work both ways as well. Yeah, so I think we don't necessarily have to wait for formal infrastructural collaboration. We can just kind of establish links in the communities within which we work. Thank you.
Okay, thank you very much. Just put those hands up again. There was like the whole team. Okay, we'll see how it goes. We'll start there, and then Desmond, and then Mary.
This is Tandi Panadi here. I'm currently from the Western Cape, but I used to work in the rural Eastern Cape. And I think the one thing that just really struck us or made us change our mind view was we were working with a child with cerebral palsy, and they just never came to appointments. And every time we saw them, the child had got worse. And when we actually just sat down and had a conversation with the mother, we then realized that the mother had bipolar, and that's why all of this was happening. But also that the mother had taken the child to a traditional healer, and that's why we weren't always seeing the child. But what then transpired after that was that the reason why they went there was because the traditional healer was looking after the mother's bipolar disorder, and she had to put someone else in charge to take after the child. And the traditional healer had actually done a great job at looking after the mother for her bipolar mood disorder and done something of looking after that child. And it really just made us rethink the whole thing of you really need to dig deeper and understand why this is happening. It's not because someone isn't like it's the mom has bipolar mood disorder, so you need to dig deeper and think about why the mother's doing that. Does the mother have enough knowledge to do that? But also the traditional healer had their own way of treating it and looking after the mothers. I think that's just what I really wanted to contribute about looking. I know everyone always jokes about me going on and on about the ICF, but I think it's such a great tool, but just going again around person-centered care and really looking at what's going on around environmental conditions.
Thank you. Desmond Kehakile from Hanisa in the Northwest. Yeah, I just want to touch a few things, and thanks to the same for the presentation. And I think we also need to look at the positives of both sides. one of the, I think, power or the advantage on the traditional healer is the accessibility. Because you find out that more people, especially in the rural area or in the peri-urban nowadays, the accessible healthcare for them is the traditional medicine. So maybe we should look at and how do we best utilize that. And the second point that I want to raise is sometimes how do we relate or connect the traditional beliefs, the traditional practice and traditional medicine, and in different areas and in different as diverse as it is, because I mean, you go to how the beliefs around childborn, the beliefs around initiation, the beliefs around death, and it differs in all other cultures or tribes. So how that now would Western medicine come in, because a disease can come whether you are at initiation or during the death or wedding, whatever. So how do we work with that? So I think it's a very challenging concept. The last one, I just want to share experience. As I'm speaking, we are having in our village, we have a known traditional healer that has been there for years, conducting initiation, and the people will go to him. So I was called in a consulting room last week, Thursday, by another doctor to say that there is this old man here who's refusing to be admitted. And because we are from his village, he wanted to speak to him. The child is a nurse. So I spoke to the child and he said, no, that he does not want to hear anything from us. So I went to him and then he was confused, septic, and then yeah, he was saying septicemia. So I asked him what's wrong, and then he said, no, I went to this traditional healer who had asked him to help me, and then the guy was drunk, but he helped me. So its consequences, this guy is the traditional healer himself, and it's 92 years. He's not practicing anymore, and he has a son that is practicing. So he said, you know, nowadays what we are seeing is that how people are losing our culture and how traditional healers of recent are practicing. So this man has cut him in such a way that he developed abscess, and he that developed. So he had an abscess on the epigastric area. Luckily, the abscess was not inside. And then he was refusing the admission to say that I think it's the ancestors who sent me there. So if I have to die, let me die. But I had to speak to you because of your influence in the society. My influence in the society is because I'm related to Royal, and he was working with my grandfather and all that. So he said the only people that I can speak to is Percy. So I don't know what to think. So I had to tell him to say that, you know, this is going to kill you. The man was dehydrated, abscess very bad with cellulitis around it. So I have to tell him that get admission. They will probably discharge you on Monday after 4 or 5 days, IV antibiotic, and we'll see how it developed. So I had to call his family to say, no, we're going to admit old man. And he agreed. So that is just to say that it's not that in traditional space, there's no challenges, especially nowadays that people are practicing the way they want. Others are not well trained. We have that challenges, and others, they had bad ethics like in any other instances. And sometimes we tend to only point out the negatives that happens and forgetting that even in our system, we cannot talk about the negative. We cannot keep quiet around the negatives in the Western the mistakes that we do and the errors. So I think we need to acknowledge to say there are both challenges, and how do we develop a both system and trying to find each other. Thank you.
Thank you very much. So we definitely don't have time for questions, but I promised Marika she can speak if she's quick. I know she speaks very fast. So, but we're going to have to close the discussion. We're at 9 o'clock.
So my name is Marika. I'm from rehab, and rehab is like you have to get to the point where you understand that you cannot make anyone do anything. Like unless you actually understand where they're coming from, and you set something collaboratively, you're actually really just wasting your time and you're going to get nowhere. So if we continue to fail to recognize people's belief systems, we're not only going to be unable to set collaborative goals together, but we're also going to potentially step on toes badly with our clients. So until we do so, we are going going to be both inefficient and ineffective. Thanks.
Now that was fun. Brilliant. Excellent way to get us into the day. And a big thank you to the tech guys who worked really late last night. This feels like a very professional conference. Thank you very much for all of that.